Hello and good afternoon. I'm Adrian James, the President of the Royal College. Welcome to this college webinar on understanding the COVID-19 vaccination strategy. I know that this is something that's in the minds of all of us. It's of great concern, both for our patients and for ourselves and for health workers and for the community at large. So we've got a really great range of speakers. I'll introduce them all in a moment. I just really also wanted to say that Joanna Frericks who's the Business and Policy Manager within the Adult Mental Health team at NHS England, is also here, and she's going to be taking a note of any questions that we can't answer, take them away, and we'll get those answers back to you. So thank you to Joanna. I just wanted to say a little bit about what the college has been doing. I've had a lot of communication with you about concerns about the priority list. We have the JCVI list of the cohorts, the 8 cohorts, and we wrote to the JCVI before Christmas and managed to get people with severe mental illness and the intellectual disability and those with autism actually on the list, on the priority list at level 6. And we've also recently written to them about the particular issue of clinically risky situations. Many of the places where we care for our patients, it's very difficult to get our infection prevention and control measures properly implemented with the best will in the world. So I'm still waiting for a response. I've also been raising it with Secretary of State, with Steve Powis, the Medical Director of NHS England, as recently as yesterday, and with Chris Whitty. So we are on the case, and I think we're getting a good listening ear about it, but we do need some action about it. So I also just wanted to draw your attention to the Coroner Study, which is being run. The psychiatrist involved is Tim Nicholson. I think we've got a link within the chat about this, and this is where you can actually register if you feel you've seen a patient where you have a new case of mental illness, or if you have a new neurological manifestation directly related to COVID, that you can actually register them, because it's really important that we actually have some research, some data around how COVID, which we know attacks the nervous system, how that can actually result in mental illness and neurological problems. So I will attach the link to that. I'm also very much aware that COVID has had a huge effect on all of us, all of our lives, our patients, on all of you, and thank you for all you're doing. We hear a lot about numbers, but behind numbers there are real people, and I know that some of you will have lost those dear to you. You will have lost patients. I was on a meeting the other day and we were talking about how COVID had affected us, and somebody said, well, actually I lost my husband, somebody who was about my sort of age. So there were going to be real gaps actually in our lives. And so if you're somebody who's experienced COVID to that sort of extent, then the college and all the members are there for you. So I just wanted to introduce our guests. First of all, Dr. Jonathan Leach, OBE, who is the NHS Medical Director for COVID-19 immunisations, who is right at the centre of this. Jonathan actually has been a real friend to us. He's been a listening ear. I think he really gets the issues around mental health. He'll say a bit more about that. He's not in control of the whole system. I think it's really important to be aware of that. So he'll be speaking for 10 minutes about the vaccine rollout. Alex Ruck-Keene, a barrister very well known to many of you and a real friend of the college, will be talking about the legal aspects of the vaccination. And then we'll have 3 clinicians, Mani Krishnan, who chairs our older adults faculty, Victoria Sullivan, consultant forensic psychiatrist, and Ken Courtney, chair of our intellectual disability faculty. So they're going to pass on one to the other. We'll come back and we'll then have time for Q&A. I've had some questions already, but if you can post your questions in the Q&A, then please do, and we'll pick those up and we'll get as many of those answered as possible. So I'll pass over to Jonathan. Thank you very much indeed for joining us. You are, I think, one of the busiest people in the NHS at the moment, and it's really a huge programme. So thank you for joining us.
Yeah, thanks very much, Adrian, and a very good afternoon to everybody. So as Adrian says, I'm Jonathan Leach. I'm a general practitioner here in Worcestershire. I'm actually also Joint Honorary Secretary of the Royal College of GPs. So actually, I'm have a role there. So I understand very much how the roles of the Royal Colleges can actually assist us at this time. But I'm particularly here speaking as the NHS England Medical Director for COVID vaccination. So it's an enormous job and an enormous task. So what I'm going to do is just give you a sort of a rundown, and then what we'll do at the end, if you've got specific questions, I'm very happy to take them, or obviously with colleagues on here. And also I'll be very clear. If I know the answer, I'll tell you, but also this is an unfolding situation, particularly obviously given where we are with COVID-19 and the infection and things like this. So I'll do my best. So let's just say, but firstly, as I say, thank you very much. So actually, as the UK, because we're across the UK, but I'll talk specifically about England. Obviously, we're doing pretty well in terms of delivery. Today's data is we're up to about 6.9 million vaccinations, which is an enormous number, actually, when you think about it, and especially given the context that the vast majority of those have been delivered using the Pfizer vaccine. As you know, there are two vaccines that we've got. The one which we started just before Christmas, which was the Pfizer vaccine, and then we got the AstraZeneca one, which was authorized just after Christmas. The AstraZeneca one is a more easier one to deliver in that it's more like flu in terms of sort of cold chain and things like this, whereas the the Pfizer one, get the right way around, is complicated because of the cold chain requirements. It's a very fragile vaccine, which is the reason why it has to be transported at -70. So actually, the fact that we've done that across the piece is very good. There are three main delivery models. One is through hospital hubs. They set up first because of some initial concerns, which I must say haven't been followed through, thankfully, about allergy, and perhaps you can ask me about that. So hospital hubs, local vaccination services. This is generally GP surgeries banding together to deliver this. So there are over 1,000 of those across England, and the bulk of the vaccinations have been given through those. And then latterly, we've got the METS vaccination centres. So I've been to the one in Birmingham, I've been to the one in Bristol. There are a couple here set up in Worcestershire, and they're dotted around the country. And actually, longer term, I suspect they will become, if you like, the major engine for the vaccination programme, particularly for the rest of the population, because there's something about hospitals and GP practices obviously need to be getting on with the day job, so to speak. So of that 6.9 million, the good thing is that if we look at the JCVI, obviously priority was given to care homes and care home workers. We've now vaccinated well over 80% of care homes. Again, given the way that we have to move it, it's an astonishing tribute to everybody that's been working absolutely flat out. And also we've now vaccinated over 80% of over 80s. So again, when we look at the risk factors, age is predominantly, above everything else, remains the major risk factor amongst all the groups. So again, that's an enormous achievement. And then in the news last week, because we've been very effective in terms of that, we're clearly now going down the cohorts, down to cohort 4, and particularly to this audience, that would be those who have a wide range of sort of serious medical problems, particularly the shielding group, which is important. Also in cohort 2 is the importance of health and social care professionals. Many of those have been attending either the hospital hubs, or when I was vaccinating week last Sunday, we deliberately in a PCN site, we're actually vaccinating a lot of health and social care professionals. They range from social workers, psychiatric nurses, physiotherapists. I vaccinated administrative staff from the local emergency department, consultant physicians, and probably thinking of every group that we can think of. So actually, overall, I think that it's going well. but clearly we need to make sure that we move through the cohorts as fast as we reasonably can. It's got to be safe. That's probably the Amazon van outside, but hopefully my daughter will pick that up, as I knew it was going to happen. It's that we need to get through the cohorts as fast as we reasonably can, but it's got to be in a safe and effective way with patient experience. And one of my roles, particularly with the nurse director, Professor Jenny Hall, is to make sure that we meet the necessary pharmacovigilance requirements that actually, for example, vaccine arrives where the cold chain of being requirements have been met and things on those lines. So there's been quite a bit of debate around when the two doses should be. Clearly, you will have seen that in the national press, and various organisations have taken various stances on it. The view I have, and again, I'm not on JCVI, but I spoke to many people who are, I am persuaded that the balance is, and particularly with the increased infectivity of some of the more newer strains, I am persuaded that rather than raising, for example, the level of immunity from around 89 to 90% to 95% with the second vaccine, that actually at a population level, and it is a balance, that it is better that we vaccinate more people in the short term. That debate is running. We could have a discussion about it, but I am persuaded by that. And I'm not necessarily always persuaded by these things, but I am persuaded. And I think when we look at doing the most for the most, that's a very important thing. We're also very mindful of inequalities. We're concerned, if I take flu as an example, that for example, Black, Asian, minority ethnic groups are not well represented in, for example, the delivery of flu vaccination. So we are concerned about that, and I think colleagues will cover some of that. And particularly, obviously, where you might have somebody who might be at home with mental health illnesses, that we would want, obviously, to facilitate vaccination for them. And I think where you particularly can help is helping in providing information, guiding them, and obviously encouraging them to have vaccination, particularly given the fact that they're often at higher personal risk themselves. And then finally, we're also mindful of those who are in the secure estate, in prisons and things like this. I've been working quite a lot with my NHS England Health and Justice colleagues to make sure that actually we have vaccination in that environment as well. The context is important, but obviously if you are an older patient in a prison, you are entitled to exactly the same level of vaccination as anybody else. And I think that's a really, really important principle, that equity right across the country is a really important thing here, so that it doesn't matter who you are, it doesn't matter where you are, it doesn't matter really about anything else, but it's about equity. And so the discussion is not about whether or not you get vaccine, it's more about when you get vaccine and making sure that equity is done properly. So we're also doing things like, for example, very mindful of some people with mental health difficulties may not be actually registered with a GP or may not even have an NHS number. And we're just finalising details so that actually we're not worried about if you're not registered with a GP, that's not an issue, but we've got a workaround so that if we've got somebody who doesn't have an NHS number, that actually at a population level and individually they can be vaccinated. So a huge amount of work. I must say, I must pay testament to everybody right across the system, whether or not it's people vaccinating, whether or not it's the practice managers, the administrators generally. Actually, the people probably who are the unsung heroes are the logisticians. I've got a relatively easy job vaccinating. It's a very pleasant thing. People are gracious and grateful, is my experience, having now done several hundred, including in care homes. But the people behind the scenes are really the logisticians, which actually it is an amazing and really complicated system in order to be able to deliver this. So Adrian, I'm going to stop there. I could probably go on forever because I can bore for Britain on lots of things, but I can certainly bore for Britain on this, I'm sure. But I think I'm going to stop there, hang over to Alex, and then as appropriate, I'm happy to pick questions up later. But thank you very much for inviting me, and I hope those introductory remarks were helpful. But thank you very much.
Great. Thank you very much, Jonathan. And thank you, Adrian, for the invitation, and to everybody at the college on the support side for setting this up at such short notice. So what I'm just going to do is I'm going to spend 5 minutes just going through the kind of legal basics, focusing in particular on adults and therefore the Mental Capacity Act. I can do it in 5 minutes, partly because I've been told to do it in 5 minutes and I'm relatively good at following instructions. And also because luckily there's material to which I can point you to help you think this through to make sure you're operating in a legally compliant and a legally confident fashion. And also because there was a useful, it was as if they knew we were having, the judge knew we were having this webinar this afternoon. There was a court of protection judgment handed down yesterday, the first court of protection judgment, thinking about both capacity and then best interest in the context of the COVID vaccine. And I'll put links to both of the guidance note I'm going to talk to in a second, and also the judgment in the chat function when I've finished. The judgment, called E, reinforces that in general, the capacity determination here, in other words, does the person have capacity to agree to have the COVID vaccine if it's offered to them, should be relatively straightforward, especially if it's possible to obtain supporting information and obtain information and support from people who know the person, and to enable that person to be operating in a supportive environment. Fully appreciate that many of the people on this webinar, it may not be quite as straightforward that because of the complexities of the client group you're working with and their personal situations. But it was helpful that as a starter for 10, that Mr. Justice Hayden, the Vice President of the Court of Protection, indicated the capacity assessment should not, in general, be very difficult. And of course, we're always thinking we're mindful of our obligations to seek to support individuals to take their own decisions. If you can't support the person to take their own decision, then of course we're in the best interests zone, unless the person's made an advanced decision to refuse a vaccine. And it is conceivable that you'll come across somebody who's made an advanced decision to refuse vaccine. There is an interesting question, by the way, if a lawyer ever says interesting, everybody else should always panic, an interesting question as to whether a vaccine constitutes life-sustaining treatment. If it does, then the advanced decision to refuse that vaccine would have to be in writing, witnessed, and to say it's is to apply even if life is at risk. We don't think in my chambers, we've been working on a guidance note on this, we don't think it does, which means that the advanced decision could actually be oral. Of course, at that point, how do you necessarily know that it's valid and applicable? So assuming that there's no ADRT, there might be somebody who has a power of attorney. Please, 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 a few red flags about powers of attorney. If someone says, I am a health and welfare power of attorney, please make sure it is registered with the Office of the Public Guardian. Otherwise, it's not a power of attorney. If it's an enduring power of attorney, that person has no decision-making authority in respect of health and welfare matters, including vaccination, but they are very likely to be someone whose views should be obtained as someone interested in their welfare. If there is a lasting power of attorney, they are the person who gets to decide, does the person have the vaccine or not? They have to make that decision in their person's best interests. If there's a disagreement about whether or not it is in their best interests and everybody else thinks that the person should have it and the attorney says no, and that can't be resolved, the only place that could be resolved is the Court of Protection. Absent ADRT or a lasting power of attorney or a health and welfare deputy appointed by the court, there are very few of those about. You are very unlikely to come across one in this context. Absent all of those things, we are in pure best interests territory. And the Court of Protection that Mr. Justice Hayden E case gave a really helpful reminder of two central things here. The first is we are looking primarily to see, is this the decision? Do we know what decision the person would have taken? In E's case, it was very helpful to know that E was somebody who had always pre-dementia, striking in such a way that she no longer had the ability to make her own decision. She had always been somebody who would wanted to be vaccinated, for instance, flu, swine flu. So that really strongly pointed to what E wanted. If we know what E would have done or the person would have done, and that would have been to say, I really don't want it, it doesn't mean that it's not in their best interest to have it, but we would need to think carefully about why it would be in their best interest. And they're obviously going to be the level of risk in particular to which they're exposed, comorbidities, other things like that. For purposes of working out what they would have done, consultation with those nearest and dearest, in legal terms, people properly interested in their welfare. The point I can't emphasize strongly enough, and it's as if we managed to get the judge to say this, which for our purposes is very helpful, he did, it's to understand and fill in the views of the person. It's not so much to relay what their views are about vaccination. So all of that comes together in a best interest decision whether to have it or not. One thing I just want to flag, and I'm incredibly aware of the level of medical expertise here, and I might almost just put it as a question to Jonathan for him to respond to in due course. My understanding is that as yet, we don't have evidence that the vaccine, either of the vaccines, means that you can't catch it and then possibly still transmit it. It means you won't suffer the ill effects as badly, which means in the context of best interest decision making, if that's correct, one of the factors is not going to be having this vaccine is going to protect other people. It's predominantly and primarily about the risk to the person themselves. But I'm absolutely the first to say I'm not the clinician here. I will defer to the medics as to the evidence there. So I'm going to stop there. I'm going to put into the chat function the link to the e-judgment, the summary I did of it on my website, because that's the kind of easy read version for those in a hurry, and also a link to the vaccination guidance note that I did. So that's the view from the law, and over to the next speaker.
Thank you, Alex. Good afternoon, everybody. I'm Mani Krishnan. I'm an old age psychiatrist. I would like to start with a couple of cases. Thanks, Alex, because my talk came in quite nicely. We're talking about patients with dementia, people with dementia, how we support them with regard to vaccination. I'm going to give two or three examples. I'll start with a simple one of somebody who has got early dementia. I've got a patient, 82, Parkinson's disease with dementia, still able to give consent and has got capacity. But the biggest problem he had was he couldn't understand the complexity of what's going on, why he has to do it. And we needed some time to discuss with him. He is somebody, as Alec earlier mentioned, was somebody who didn't bother taking flu vaccination. So we needed a lengthy discussion explaining the risk benefit and why he need to consider this. And he made an informed choice that he is going to book himself to have a vaccination. That was the person with dementia but had capacity. And the second person was in one of our wards. The person did not have capacity, moderate to severe dementia. There was a lasting power of attorney for health and welfare from the family. And even well before the vaccination started, family have clearly given their wish for their loved one to be vaccinated. And it was recorded in the care plan. And when the time came, that was last week, one of our inpatient ward was vaccinated. That person got vaccinated. And then in the chat, there was a question. And incidentally, I've got a third case where you talked about incapacitated patient, what the family are not consenting to the vaccination. This was quite a tricky one where the primary care rang the person and they booked the patient to have the vaccine last Saturday. And then I was incidentally ringing this patient for a regular clinic appointment. And then the daughter said that she saw it in media that some celebrity, I won't mention, it's not fair, that they are not going to take a vaccination. So she's not going to take her mother for the vaccination. So again, a lengthy discussion with the daughter explaining the risk benefit for her mother, and she was able to understand, and she agreed, and thankfully I knew from Monday that she took mom for the vaccination. So it is about lengthy discussion and negotiation. And I was just going to quickly share a little pointer. We will put it on the chat for you to have a look at it. So basically, if you look at this is there in the Dementia UK website, give visual aids, assess capacity, which Alex has already nicely mentioned, choose your moment if patients are variable in their presentation, communicate clearly, individualized approach, never rush, engage family and relatives. And this is just like some few things, like it will protect you from the virus, it won't give you COVID, and then it's about giving them advice and permission. So it will be really useful to discuss these things, and considering our older adults, they can take time. We need to discuss with their families, and also giving them clearly risk benefit. Sometimes if they can't make a decision, going back to them again and then discussing again would be very useful. What we find is, again, just a tip for people, is in our inpatient unit, even well before the run of vaccine, we consented those who are able to consent, and we discussed with the family for those who have not got the capacity, so that we were lined them up ready for them to have the vaccination. So it is about preparation, negotiation, and clear information. If needed to go back, would be quite a useful way to consider vaccinating our patients with dementia. I've also put another link from Alzheimer's website for you to look at it, and I will also put the link on this infographic I've just shown. I think I'm going to stop there, and I'm going to hand over to my colleague Ken to give his view. Thank you.
Thank you, Manny, and good afternoon, everybody. I'm Ken Courtney, consultant psychiatrist working with people with intellectual disabilities. We know from the learning from the LEADER report, which is the Learning from Death review, that people with intellectual disabilities are in fact dying 20 years younger than in the general population. And with the advent of COVID-19, that has increased the rates of death among people. For example, in a study conducted by the faculty last year, we found that this group of people who had suffered from COVID were dying at a younger age. So this suggests a biological vulnerability that people are actually manifesting, and around the question of their biological age as opposed to their chronological age. The Public Health England reported also that the rates of death in the population of people with intellectual disabilities is 4 times higher than in the general population, and where the deaths haven't been recorded is possibly 6 times higher. So this is obviously a huge concern to all of us supporting people with intellectual disabilities, and great concern in services, but to their families as well. We note too that the JCVI groups have not included people with intellectual disability as a priority group. People with Down syndrome are in group 4, which is very welcome. However, other people with intellectual disabilities are being assessed according to their chronological age, in spite of the fact that the rates of physical comorbidities are high in this group. When it comes to the issue around capacity, mental capacity, to do with the vaccination program, of course, we will be working with people who do have mental capacity, who understand the issues, and often our task is really to inform them, and we can do this through using materials that are easily available and which have been developed by many groups, such as Learning Disability England and MenCap, to support people in terms of getting the vaccine. The issues around supporting people who don't have mental capacity, particularly those with more severe, profound intellectual disability, and people with autism too. Again, we would follow the best interest route when considering the vaccination program for them. The big challenge to us working with people with intellectual disability is really the support to support staff, families and support staff, to ensure that they are actually preparing people for the vaccination program. The consent forms are available on NHS England website, which people can actually complete as in preparation for the vaccine, and we in services are encouraging support staff to do this. In more difficult situations where the staff might find it more of a task to gain consent from a person, the local community teams would be more willing to consider completing capacity assessments on people. So this is what we can actually offer with regard to the vaccination program. The other areas that the health service actually needs to consider is around making reasonable adjustment for people with intellectual disabilities when they do present their services. And this could be about offering people the opportunity to have the vaccinations at home, especially where they're quite fearful of going to health services or where they're afraid of injections. And because of this, our community staff, support staff need to be working with health workers to assist people in getting the injection. So just to summarize, people with intellectual disability are a highly vulnerable group to contracting coronavirus. And also the mortality rates suggest and confirm this vulnerability. So many people working with people with intellectual disabilities consider that they should be a high priority group for the vaccination program. And also just to emphasize how important it is to prepare people for the vaccination and the steps that we can put in place. Thank you. I'll pass on to Victoria.
You're on mute, Victoria.
We still can't hear you, Victoria. Unfortunately, we can't hear you. Adrian, should we go straight to Q&A?
Great. I think you can hear me. Victoria, do you think you're on now? Do you want to see if you can go? No, we still unfortunately can't hear you, Victoria. So we'll see if if you can fiddle with your audio, and we'll come back to you. I'm going to we'll do a few questions, and then we'll come back to you, Victoria. The first question really, I think the issue that people are most concerned about is the delay for the second dose. Lots of questions about this. What's the evidence for the delay? People saying, well, at one point, the efficacy in relation to the first vaccine was 52%, then it was suddenly changed to 90%. Why is that? What's the plan for the second dose? And can we be sure that older adults in care homes will get their second dose? I think, Jonathan, it's probably a question for you. Do you want to come in and just answer the question around the evidence, the delay, and what are the plans for the second dose?
Yeah, thanks very much, Adrian. This was the question I was expecting. So let's just stand back for a second. So what we've got are two vaccines. The data on the Pfizer vaccine goes out to 3 weeks. And if you take the overall data across those 3 weeks, then it will give you an efficacy around about the 50% mark. And essentially what happened was that there was a reanalysis of this, and it's on the basis, and there is a logic to this, that if I was to come and vaccinate you, Adrian, then initially your immune system wouldn't respond for a sort of a couple of weeks. And so essentially what they did was then do a reanalysis of that later period. And that's where they get this data from in terms of the 89 to 91%. So that's where it comes from. And actually it's reasonable. And so I'm a general practitioner, but I'm not an immunologist, but I am persuaded by this, that the immunologists are all of the view, or those I've spoken with, of the view that's a reasonable thing to do, because actually we wouldn't expect the immune system to respond in the first couple of weeks anyway. In terms of the looking beyond that, the view is that if you're going to get that level of immunity, it would be very unlikely to dip. And actually, again, the immunologist would say that there's an argument that actually pushing it out later might actually mean that the person would get a greater level of response, and actually maybe for longer. So if you like, that's where that comes from. In terms of the AstraZeneca, it's worth remembering, and I do commend to you, there's a very good BMJ podcast with Professor David Pollard, which is on the BMJ website or available on your podcasts. There's one by David Pollard, who's the lead investigator from the University of Oxford. Various things. Firstly, actually, they were going down a one jab policy to start with, but actually found that it was more effective at a second. So actually, they do have data going beyond. So and so what we would say is that on one jab, it's about 73%, and on, which is still higher. Let's just put this in context. That's still considerably higher than, for example, the BCG vaccine for tuberculosis, as an example, which might be around about 50 to 60% for respiratory disorders. So it's still a very good vaccine. So I think, you know, the arguments are there, and, you know, I think that in a perfect world, then we would have enough vaccine to be able to follow exactly what happened in the trials. I get that, and I think everybody gets that. But, you know, the government and the chief medical officers in particular, as their main professional advisors, have had to make a judgment. And that's essentially in the CMO's letter, which I think came out something like the 30th of December. So that's online if you want to have a look at it. And JCVI agrees with that. So essentially, that's where we are with that. In terms of second doses, what I can tell you is that NHS England's plan is exactly that people will get their second doses. We're really absolutely clear that actually the second dose is needed. It's needed to boost the immunity for the reasons I've said, and to give the longevity. So there are absolutely, as I sit here, and I'm not going to blag you, there are no plans that I am aware of that would say that that would go beyond 12 weeks. And actually the call recall system that we've been working on and within general practice is such that people would be called for their second vaccine. So just as, for example, I was spending quite a few days vaccinating in care homes for a lot of our own, my own patients, we will be doing it again. And I think that probably answers those questions. So I know of no plans. I've not seen anything, and all the intentions are that people would have this, and that it's as much as an assurance I could give people. And I wouldn't, you know, I'm not trying to blag people or anything. That is what I believe, and that is what I see. Is that okay, Adrian?
Yeah, that's great. Thanks, Jonathan. And I should say that I sit on all the meetings with the Chief Medical Officer, but you have all the other Royal Colleges there who have, you know, we have full and frank discussions, and the colleges, the pathologists and the Society of Immunologists, they do feel that the rationale is there. So they are actually supportive of it. And I think they would certainly be saying something if they weren't. And NHS England, and I raised this with Steve Powis only yesterday, are aware that getting the second dose is a bit of a game changer. And the Chief Medical Officer said that actually when you get towards the end of 12 weeks, then it does flip the advantage. Once you've vaccinated the first 4 cohorts, certainly it does flip back to saying, well, you've actually got to give the first 2 the second dose. I'm going to ask one more question of you, Jonathan, and I'm going to go to a legal issue. And the question this time is around if somebody has had COVID-19, can they have the vaccine, and how long after recovering can they have it? And then another supplementary question, why don't we differentiate between those who have COVID, and we believe there is some protection, and I think it's 83% protection at 5 months if you actually had COVID. Why don't we differentiate in relation to having the first dose, or just give effectively a second dose because you've actually had COVID?
So I think there's still a debate going on as to how much immunity natural infection gives you. So it does seem to be emerging that there is some immunity, but we don't really know. This is still a new disease, of course. And I still think it's astounding. I qualified far too many years ago, but I think it's astounding in a year that we've got a vaccine or several vaccines, which science and humanity have been able to deliver. So it's absolutely astonishing and astounding. Although I must say, I'm not worried about shortcuts being taken. I'm quite confident that that's been all done properly. So the first thing is that if somebody's had COVID, then actually they should still be vaccinated as we would recommend. However, there are some cautions that if somebody is unwell, they shouldn't be. And that's the same as any other vaccine in that respect. Actually, if you come in with a fever, if I'm vaccinating a child, they're unwell with a fever, we wouldn't vaccinate. It's exactly the same. The caution is actually to put it out to beyond 2 weeks and probably 4 weeks. And this is in the Green Book. And that's really, so again, we're differentiating any potential side effects, which might be as a consequence of the vaccine, from actually continuing symptoms from the infection. So essentially, that's where it is. In terms of the choice between, there are very specific medical reasons why somebody may or may not want a particular vaccine, particularly around the when we were more concerned about allergy than we are now. But broadly, the view is that across the piece is that they're equally effective. And also, just to pick up, you were talking about homeless and things like this. Where I think we need to get to is a place where actually COVID vaccination just is seen as part of what we do. So just as, for example, I know of lots of community psychiatric nurses might deliver flu vaccination to people in the community and those with mental health difficulties and are housebound. And that's a really important part of what they do. It really is important, given the physical nature of, the physical risk as discussed. Where we need to get to eventually is that it would be doing the same. And where, if I was to polish my rather murky crystal ball, I could imagine, COVID vaccine in the left arm and flu jab in the right, or something like that. But we're not there yet. And what we're having to do is to run through this prioritization. And it is, when I've spoken to Professor Lin-Wei Shin, who chairs JCVI for this, he's very clear. It's about saving lives. And so that's the strategy. It is about saving lives on the risk. And that's where we are. And we're going through these cohorts. But I hope that's helpful, Adrian.
Okay, thanks, Jonathan. I'm going to ask a legal question now and then go back to you, Victoria. You may want a view about the legal question. There is one question about overcoming vaccine reluctance from families of those who lack capacity. The legal judgment has been put in the chat there, which I think is really all about that. But Alex, you may want to say more about that. Then there's another question, and one that I also wanted to ask about, would you ever use force to restrain somebody if somebody lacks capacity in order to give the vaccine? And then I'll come to you, Victoria.
Brilliant. Well, thanks, Adrian. So yes, I'm really glad that the questioner used the term vaccine reluctance. I think that's a really important framing, because that then allows the discussion about why are you reluctant, as opposed to some of the other framings which are setting you up in immediate opposition. So I think my first thing is the engaging with why are you reluctant, what is the basis of your reluctance, and then the e-judgment makes it extremely clear, that which we already know, but it's really helpfully spelt out in really kind of simple terms, that at the end of the day, that when we're thinking about decision making in relation to somebody with impaired decision making capacity who can't consent for themselves, what's of most importance is to understand what they would have done. So the doctors, the clinicians, the expert in the patient, the families, people who care for them are the experts in the person. And it's trying to disentangle whether the reluctance is, in E's case, the reluctance, the judge was clear, was on the part of the son, reflecting the son's very specific views, as opposed to on the part of the mother. I mean, there will be other cases coming through the Court of Protection which have to, as it were, tease out some of these things. Can I emphasize, I am not saying all cases where there's disagreement need to go automatically to the Court of Protection, but at the moment there's an understandable degree of kind of ranging shots to work out the band of reasonable responses and how to think about things. So I think it's about communication, it's about sharing information, it's about pointing to reliable sources, it's getting a trusted voice. If we've got in particular a problem with, in E's case, although the ethnicity is not spelt out in a judgment, it would appear that it might well be that she was Afro-Caribbean, and it might well have been helpful in that case to have engaged someone from an Afro-Caribbean background to be able to speak through and understand where this is coming from, potentially. So that is probably a bit of an application of that first one. And that second question of, is it ever right, or could you ever use force to bring about vaccination? I mean, from a legal perspective, yes, you can. Mental Capacity Act, Section 6 says you are allowed to restrain somebody if it's necessary and proportionate to the risk of harm that they would suffer otherwise. But just because you can do it legally doesn't mean you should. And I saw Manny's answer in the chat function, or in the Q&A function, was essentially, over my dead body, would we be doing that? And Manny is coming from that, and I completely get this. I'm going to make a guess here, but he's coming at that from a clinical perspective. Why on earth would we want to do that? I do think there is a spectrum, because it depends what you mean by force. I mean, overcoming fierce resistance is one thing. One thing, at the other end, is somebody who might require some gentle persuasion, which goes beyond, as it were, just verbal. And so there's going to be that spectrum, and it is important to work out, is this necessary and proportionate to the risk of harm the person would suffer or otherwise? Can I just completely reiterate, this is about risk of harm to the person. This is not, I want to vaccinate this person to prevent them possibly causing a risk to others, not least because we don't know yet whether that's even a defensible line of argument. While I'm on, can I just very quickly answer that question which came in about why on earth was this case in the Court of Protection, the E case? It was in the Court of Protection because there were already proceedings and the issue then came up. So many situations, there is no need to go.
Okay, thanks very much for that, Alex. Victoria, should we come back to you? You may also want to give your own view about use of force.
Yeah.
We can vaguely hear you, Victoria, but it does look like a very, very poor connection.
See if that makes the audience.
Yeah, I do apologise, Victoria. Do you want to have a go with your camera off? Yeah, I'm really sorry, Victoria. I think that's probably not going to be possible. I do apologise. And if there are particular points that you need to make, we would find another way of actually getting those issues across. I'm going to go to another question, and that is about, from an intellectual disability point of view, that there's a question about that there are people in supported homes who have intellectual disability. I think this applies to older adults as well, they're not registered as care homes, so they don't come under the first cohort, but they are living in very similar situations with maybe with other people, with staff there giving support. Where do they come in the cohort? Ken, you may want to just say a word about that, and we'll probably go back to Jonathan about it.
Indeed, this is a big concern of ours. So what we're talking about are people living and supported living in the community, and places which may not necessarily are regulated by CQC, for example. And yet these people are at a special risk of contracting the virus through the support workers coming in and going out. But also they're often young people who have good access to the community, who may not understand the risks that to themselves of interacting with other people in the community. So they are particularly at risk of contracting it, but also of spreading the infection too.
And Manny, did you want to just come in, and because I think there are older adults in a similar position as well?
Yes, there are, and again, the extra care setting as well sometimes is not classed as a care home. So I have got quite a few vulnerable adults, like they are like 79 and an extra care home with severe 20 years of enduring mental illness. So there are some disadvantages of clearly cutting these things. And I do think that that's something we need to be working on. But luckily, I was told this week that they're doing 70 and above. So we're trying to work on whether they could, like, as I think Jonathan made a point, whether we can go into the community and give them these, vaccine. That would be the way forward.
Okay, I'm going to come to Jonathan. Before I do, Victoria says, apologises in the chat. No apologies necessary, Victoria. It's NHS Internet, apparently. And Victoria's going to talk about scenarios in relation to best interests in secure services. So we'll try to get back to those. But Jonathan, do you want to talk about the people in supported homes that aren't registered as care homes?
So, and I think Manny's point is absolutely right. Actually, of course, the whole strategy is to get vaccine to the population as fast as we can. So, as you know, Adrian, from the conversations through the Academy of Medical Royal Colleges, I've had approaches from a wide range of groups with justification, actually, all with justification that their group should receive vaccine ahead of other people, and I get that. The strategy, though, is to get vaccine out as fast as we can. So if we talk about the patient that Manny was talking about, a 79-year-old, actually, they will be they are in cohort 4. So we are on track. We are on track to deliver to cohort 4 by the middle of February. Okay, we've got still a little bit to go, but what I'm seeing here and what I'm seeing nationally is that actually vaccine is being rolled out as fast as we physically can. And certainly we're not holding it in freezers, I promise you, it's getting out as fast as we can. So actually, to pick up Manny's point, they're there. Where we are concerned is obviously making sure that we identify those people. So we as general practitioners have a list of housebound. We do need to be mindful of, and that's across the piece, it might be somebody with dementia as an example, and that would be a very common thing. That, I can vaccinate probably 10 people in an hour at a vaccination centre, whereas it would be likely 1 as a home visit. And we just need to remember in terms of the difference that makes in terms of vaccinating to a large number of people. So we absolutely get the importance of vaccinating those who are truly housebound. I get that. But at the same extent, we also would like to encourage those people, perhaps with support, that actually clearly, if they're able to access one of the mass vaccination sites. Now, running in parallel with that is obviously those who are in residential homes. Certainly, as I said, we're over 80% of the older age ones. And clearly, as we go down the cohorts, we're very clear. We've been looking particularly at homes where there are patients with learning disabilities to make sure that they're offered vaccine. Now, I absolutely accept, and I'll be very interested in Alex's comments on this, because for many of those, there are significant challenges in terms of firstly getting consent, although that's the same, and also best interest decisions, particularly where you might have somebody with a severe learning disability where it may be a very challenging vaccination if that's what you choose to do. So, but we're certainly looking at that very firmly now, because obviously, as has been said, these patients are at higher risk than their cohort for their chronological age, and we're very keen to make sure they're vaccinated.
Alex, did you want to come in on the legal side? And Ken, you may want to come back.
Yes. I mean, on the legal side, this has got such resonances to, for instance, everything we've learned under LEADER, which is where it appears challenging. What we've learned, and Ken will speak much more eloquently to this than I will, what we've learned is people give up too easily. And so where there's a challenge in the delivery of something which is considered to be the right thing to do is then work out how to respond to that challenge. And I think in just one sentence, the law will provide you with a way in which to respond to that challenge. So the law doesn't stand in your way. It's sometimes just fear, or it's too difficult. So I think that would be the way I would want to frame it. So please don't don't give up because it seems difficult. Think about how best to respond.
Ken, did you want to come back?
Well, just to say, I really welcome Jonathan's comments on it, because it's a real concern to us, especially when we feel that this population have been ignored in the past and hopefully will not continue to be ignored. Because in terms of numbers, they're a much smaller population than the older adults, of course. But, you know, they are younger in many cases. And as I said earlier, they die younger, and they're even dying younger during COVID as well. And it's really about equity of access to healthcare, and people being treated well, and also their lives being valued as well. And in terms of the issues that we've been speaking about in gaining capacity from people, we're dealing with those every day in ordinary practice. Even before COVID, these were the issues which are challenging us, and we have mechanisms around it. We can support people, we can support families, and we can take these decisions in legally supported ways. So I really do not want this population to be forgotten about, and I really am highlighting, you know, how important it is that we protect people from the diseases that actually they're being exposed to.
Absolutely, Ken, that's a really, really important point. Another question, just two rolled into one. Any evidence about which available vaccines are safer for those who are mentally unwell? And also any evidence around interaction, for example, with antipsychotics? I suspect it's probably too early days because so few people with mental illnesses have had the vaccine. But Jonathan, any response to that, and what are the plans to actually explore that going forward?
So let's just unpick this. So the number of contraindications for cautions is actually very small, actually, to both. So there's no egg allergy. We're not worried about breastfeeding. Pregnancy is caution, so you can give it if somebody is in contact. So I vaccinated, for example, a staff nurse who thought she was pregnant, but she was working on the surgical ward, which was the COVID ward. So we can use it in pregnancy. There are no specific contraindications in terms of medications and things as we speak at the moment. So actually, they're both thought from MHRA and others and internationally to be equivalent. In terms of the sort of reporting of things, MHRA and ourselves have been receiving sort of yellow card, or MHRA get the yellow cards. There's no particular signal about any particular group of medication or things like this, but that's really a question for MHRA, not that I'm aware of today. Clearly, unfortunately, a lot of these vaccinations are being given to very, very elderly and frail people who, you know, by chance, unfortunately, they will often pass. You know, I think there's something like 40,000 people pass a month, something like that. So by chance, unfortunately, a lot of these will pass on or around the time of vaccination. And I think we just need to distinguish that from cause and effect. And to date, I haven't seen any particular signals in terms of cause and effect regarding vaccination. Okay. Great.
So, and just to clarify, there's another question about vaccination in uncomplicated pregnancy. That's not a contraindication. In fact, we encourage people, if relevant to their cohort.
Yeah, so relevant to their cohort. So, so one of the discussions we've had, for example, is with the Royal College of Obstetricians and Gynecologists, is, for example, like the nurse I was describing, somebody who was working in that, or perhaps somebody who is in the clinically extremely vulnerable group, the shielding group. So those are conversations, just as we're having these with you, with the Royal College of Psychiatrists. There are analogous conversations with the Royal College of Obstetricians and Gynecologists.
Okay, that's great. Just one final question for you, Jonathan, about allergic reaction to AZ. Obviously, there was a lot of concern very early on about the Pfizer vaccine. Any updates on allergic reactions?
So, as you rightly said, Adrian, there was some concerns at the beginning regarding the Pfizer vaccine. We don't know, but it's thought to be the polyethylene glycol that is in it. But again, that's not proven. Most vaccines do not have PEG in them. So let's just place that there. So as a caution, initially MHRA put out quite a stringent one, which was any serious allergy to any cause. and also if you'd ever carried an EpiPen. That was a contraindication. They then looked at this again, and particularly using international evidence, and essentially it's now an allergy to an excipient, which in my simple brain is an ingredient of the vaccine. So if you've got something which is in the, and if you look, actually, the PEG is probably the only one for Pfizer, but we've still got the 15 minutes observation period. And actually that was one of the issues about, housebound, never mind moving it around, because if I was in lots of people's houses for 15 minutes, I'm sure I would get too many pieces of cake and too many cups of tea from my patients. Actually, I wouldn't survive. So I think there's something there. For the AstraZeneca, there are no specific allergy issues, except if somebody has a known allergy for the ingredients, but generally it's not an issue. And things, for example, I've vaccinated people who've had bee sting anaphylaxis, anaphylaxis to other things, people with allergies to penicillin, clearly they're not an issue. Egg is not in either. So egg allergy is not in either of them. Okay.
Great, thanks. We're nearly at an end now. Manny, is there anything that you wanted to come back on, any of the questions that have been asked, or any final points you wanted to make?
Thank you. Just, I think Alex's point about, he talked in the legal sense, but if there are reluctance and concerns, there is always a way to negotiate. I think it's about giving time, again, giving the importance of the need for the vaccine. And there was another question on, if somebody has had COVID already, do they just have a booster rather than 2 vaccines? So I think that is, again, Jonathan might correct me, I don't think that's right. It's 2 different things. You are getting, using the spike protein for protection. So I do think that sometimes the myths needs to be clarified scientifically. As professionals, we give the right scientific advice, negotiate and discuss rather than rule it out in one interview.
Great, well, that's fantastic advice as ever, Manny. So thank you. I want to draw everybody's attention to the chat, things posted around the legal judgment, around the Coroner Study, and Victoria has done a fantastic job in the chat. She's identified the issues that she wanted to get across. Please do have a look at that, and thank you, Victoria. And again, apologies that you weren't able to actually join us in the way that we'd intended. There are some other questions raised. Are we lobbying for the vaccine for detained patients? I mean, absolutely, obviously, particularly within their cohorts, but I think there are very particular issues. I'm a forensic psychiatrist. I work on a low secure unit. We've had COVID, and I think that there are particular issues, both in terms of the risk, and most of my patients are in the cohort 6, but if there are other patients who are in an environment where they are having contact with people who have COVID, and they're not actually able to actually leave that environment, whereas most people can say, I'm off. So I think there's an ethical issue as well as a potential legal issue here, and I'm arguing very strongly on that, as Jonathan will know, and it may be that there will be some changes, but we'll have to leave it there. I want to thank all of you who have joined us. Thank you for your questions. We'll have a look at the questions that haven't been answered, and we'll try to get as many of those answered as possible. A big thank you to those who have presented, Jonathan and Alex particularly, our guests, but also members of the college, Ken, Manny and Victoria. Thank you to the college staff for all the work that you've done in actually putting this event on and all the other events on. So thank you so much, and thank you to all of you for all you're doing under extremely challenging circumstances. We'll look to see whether we actually need to update this, because the vaccination issue, there will be growing evidence, and we may need to come back and actually have another webinar. So thank you for joining us, and I hope you have a good evening.
Thank you so much.